Today's lecture will be over Chapter 11 in your book. If you follow along with me, as well as your PowerPoint, we'll be talking and introing the cardiovascular system, and we'll talk about cardiovascular drugs. Today we'll focus mainly on the heart. Next week we'll get into the blood pressure and all the different classes of drugs that is used to treat hypertension. So today is a good, today we're covering drugs associated with the heart and arrhythmias, etc. So we'll go and get started. The first few slides is just basic anatomy review, so let me touch a little bit on that review. And I've included some extra slides in this PowerPoint as well. But with the cardiovascular system, we're going to talk about the heart, and we'll look at the different layers of the heart. We talk about blood, and then the blood vessels. So there you go. The heart. Take a look at the book. There's a picture on this PowerPoint, but it's not very good. So if you take a look at the book, page 164, you'll see the different layers of the heart. So when we talk about an MI a little later, we're actually talking about the inner part, because we have the epicardium, which is the outer, and the myocardium, which is the middle, and then the endocardium, which is the inside. The way I remember it, I always think of endo meaning in. But take a look at the myocardium, which is the middle part of the heart muscle. And make a note of that. So we take a look at the blood flow of the heart and some basic anatomy and the structure of the heart. We'll take a look at that as well. Well, the heart has 4 valves, Ryan. Let me go ahead and go over some of the anatomy of the heart. Well, I've got that on the next slide, don't I? Yeah. Okay, so we just went over that one. So here is the outside of the heart. The very bottom, this is the apex, and you typically don't think of the bottom as the apex, because typically apex is top, but this is the apex, the very bottom. This is your left ventricle, right ventricle, or if you want to think of them as chambers, it might be easier to look in the book, page 166. Let's talk about this. And we'll talk about blood flow. I'm not very good at drawing, but oh, I can just draw on this, can't I? I'm going to jump ahead just a couple. I'll come back. I just need this. If you were to draw the heart in half, kind of like I did. Now, remember the anatomical position, which is this way, right? Okay. So this would be which side? And we're talking about the anatomical position. So the right side, see the blue, that deals with deoxygenated blood. Okay? The left side deals with oxygenated blood. So the heart has basically 2 jobs: to bring in deoxygenated blood, send it to the lungs to be oxygenated, and then to pump it to the rest of the body. That's the job of the heart. With that said, the heart has its own blood supply. And I'm getting a little ahead of myself, but I'll go ahead and discuss it now, so we get all the A&P out of the way. So the heart is sort of like a banker. So when the banker, or a bank teller, does not take some money, if you go to the bank and cash a check or whatever, the banker does not take a 20 every hour or whatever to pay himself or herself. The banker is paid through the bank, right? Same way with the heart. The heart has its own blood supply. And when something happens to that blood supply, we have problems. And of course, we throw drugs at those problems. And that's the second part of the lecture. So right side deals with deoxygenated blood, left side deals with oxygenated blood. Now, let's take a look at a couple of things here. This is going to be the right atrium. So remember, we have 4 chambers, right? Yes, Jeremy. This is the right ventricle. Very good, very good. And again, we're dealing with deoxygenated blood, so then it's going to send it to the body. It's going to be sent it to the lungs. And then when it comes from the lungs, it's going to go to the left atrium, very good. And then the left ventricle. The job of the left ventricle, let's take a look at this. Notice the thickness of the heart muscle. Notice how this is very thick compared to this, compared to your atriums. And look at the right ventricle compared to the left ventricle. Notice how much thicker this is? Why? The answer is within the question. Notice the thickness of the left ventricle compared to the right and also compared to the atriums. Notice how much thicker it is? Why do you think it's thicker? And you can look in the book as well, in case you can't see the keep going. So the job of the left ventricle is to pump oxygenated blood from the heart to the rest of the body, right? So it has a big job to do, versus if you take a look at your right ventricle, it's only pumping it from that location to the lung, so it doesn't have very far to go. But the left ventricle, it has to go from there to the rest of the body, so it has a much, much larger job. That's why you see the heart muscle much thicker on the left ventricle than you do on the right ventricle. Very good. So make sure you can label the atriums and ventricles. Part of a test, perhaps. Okay. Let me back up a smidgen and let's see, we left off. I'll go ahead and briefly talk about this since we're here. This is on page 165 in your book, in case you can't see the computer screen that well. Now, remember before when I said that the heart is like a banker and it does not take money? It's not supposed to, at least. The heart has its own blood supply. And if you take a look, we have, you'll see the right coronary artery, left coronary artery. This is its own blood supply. If something happens and part of that is blocked, then we can have problems. And we'll talk about those problems and how to treat those problems a little later. This is normal function. So for example, let's say that we have a blockage here. Can everybody see that? Barely, with the red on red. I won't change the color. Right? Yeah. Anyway, that means that this tissue here is going to die because it's not going to get that oxygenated blood. And we'll take a look at an angiogram a little later. So we don't want that blockage to happen. When that blockage starts to appear, we're going to have chest pain or pectoris angina, and there'll be other signs and symptoms as well. Everybody okay? Bear with me? Okay. The large blood vessels are the arteries, which carry oxygenated blood away from the heart to the capillaries. So if an example of all of this, again, is on page 165 at the very bottom chart, kind of is a good explanation of how all this goes with the oxygenated and deoxygenated blood associated with the lungs and the heart. And the pulmonary arteries carry deoxygenated blood from the heart to the lungs. The veins carry deoxygenated blood away from the capillaries to the heart. And the capillaries, and if you take a look on the very bottom on page 165, the very bottom picture of the little person, that's kind of an example of capillaries. That's where the exchange is going to happen. The exchange between oxygenated, deoxygenated, and nutrients and all that good stuff is going to happen there in the capillaries. And then the blood flow, I've already talked about the blood flow through the heart. You should already be familiar with that, so I'm going to move on. I'll wait just a moment in case you have to fill anything in, but this is nothing new. Just what I told you a moment ago. Okay, now we're going to talk about electrical activity of the heart. So page 166, we'll take a look at that. And the heart has its own electrical supply. All right. I've already talked about this. We're good on this, right? Okay. Now we'll get to the electrical activity of the heart. Now I've got a better picture. So let me skip to that picture, then I come back. So we'll fill this in just a second. Let's take a look at this. Okay, so let's talk about the electrical activity of the heart. Again, let's label the heart very quickly. And if you want to draw a little line. This is the what? Right. This is the... Notice the thickness of the wall is always thicker. That's the way... So if you get confused on which is right, which is left, just take a look at the heart. Take a look at which is thicker. This heart muscle is much thicker, so we know that's the left ventricle. What about this? Okay. So again, make sure you can label that, etc. Now, let's look at the electrical activity of the heart. It's going to start here at the SA node, which is also known as the pacemaker. Now, if something happens to the SA node, well, let me talk about normal, then I'll talk about abnormal. So typically, we go from the SA node, and as you can see the little arrows, we're shooting out here, we're shooting down, and we're moving here, and we're activating the AV node. Then the electrical impulse is going to go down, and it's going to go down the bundle of His, the right and left branches, and activate the ventricles. If something happens to the SA node, the AV node then will pick up and become the pacemaker. For example, if there was some type of damage to the SA node. The book might do a little better drawing because of picture because it has the arrows. But if you follow the arrows, you see the flow of the electrical activity in the heart. And then the Purkinje fibers, which is the very bottom there, that's what goes into your right and left ventricles. Does everybody see that?
Yeah.
So again, the way the electrical activity goes, it starts at the SA node, it fires, it goes to the AV node, and then it goes down with the little arrows there. That's normally what happens. Okay. Now, I backed up a slide, so let's go over this one. The autonomic nervous system and the drugs that stimulate or inhibit the influence heart contractions. So we'll be taking a look at drugs that will cause this to happen. Some drugs will cause the heart to constrict stronger. And then if we take a look, and I don't have a copy of it with me, but I'll make sure I have a copy next time. But if you remember the chart that I gave you before, which had the sympathetic and parasympathetic nervous system on it, I'll make you a copy of that chart again for Wednesday. It's on page 90 in your book, if you want to look real quick. So, the sympathetic or parasympathetic, which one speeds the heart up? Sympathetic. Which one slows the heart down? Very good. Oh, this chart is even better than I had anticipated it being. Very good. Because this chart, you'll need this chart a little later as well. It'll help you with some questions on some of the case studies I've got for you. Okay, so we have the sympathetic, parasympathetic. So sympathetic speeds it up, parasympathetic slows it down, right? Sort of like a seesaw? Yeah. Okay. So if you want to make a note somewhere about that as well. And so I just summarized this slide. I've already discussed this. So which node is the pacemaker? Very good. Okay, now we're going to talk about some conditions. So we sort of talked about the normal activity of the heart, normal functions of the heart. So now we'll talk about conditions. We'll look at some different types of heart disease. So we'll look at coronary heart disease. You'll see that abbreviated as CHD. Coronary artery disease. And they include pectoris angina in there, or angina pectoris, which is just simply chest pain. And then last but not least, myocardial infarction, which is a heart attack. So if you notice the myo, which is the middle part of the heart muscle. If you look back on page 164, the different layers of the heart which you have memorized, you'll see that the heart muscle is the myocardium. For ischemic heart disease, the basic problem here is that the heart needs more oxygen. So something has happened. The heart does not have sufficient oxygen. Something has happened. There's a clogged artery, or something is going on where the heart is not getting sufficient oxygen. So that can lead to heart failure. It can lead to certain arrhythmias. We'll take a look at some arrhythmias momentarily. Even death. So chest pain is not good. You can always abbreviate oxygen as O2, and that's acceptable for quizzes and exams and such. So if you ever need to abbreviate it. So if you don't want to write out oxygen, you can just put O2. Okay, so now we're going to talk about some different conditions which will affect the arteries. So atherosclerosis, which is a degenerative change in the small arteries, and usually this occurs in your geriatric patients and your diabetic patients. And I've got some examples of that in just a moment. Also, the elasticity is lost. The walls become thick and hard. And the area inside becomes smaller as well. And we'll take a look. Bless you. Which we'll get to in a moment. I got some pictures. And the way that is categorized is by the plaque, which is formed. And we'll take a look at the plaque in just a moment. That will build up. This can build up the aorta, your coronary arteries, etc. So here we go. I got a couple different pictures for you. Normal, we're good. Here, we start to have some problems. As you can see, we start to build up, So the less oxygenated blood is flowing through here. Then I've got a real life picture next. As we can see, the plaque is building up. Not a lot of room for the blood to flow through, for the oxygenated blood to flow through. Here's an example of a normal one, a normal artery. Here's an example of an artery that's been obstructed. Again, notice the plaque build up. So what's happening, if you can picture, if you want to flip back to the other page, page 165 at the very top, if you look at the heart, look at the left and right coronary arteries. So imagine one of your coronary arteries looking like that. So so the heart demands more oxygenated blood. Let's say that you're walking or just doing everyday activities, and now the coronary artery has been obstructed, so you potentially can have chest pain, pectoris angina. Everybody with me? Everybody kind of see the flow here? We'll talk about treatment drugs and such in just a moment. And again, I just broke that up and showed you a couple. It's the same picture as before, but there you go. Is it that boring? Okay, I've already talked about angina pectoris. That's just chest pain. The heart is not getting enough sufficient oxygen. And there's a couple different types. Pectoris angina, we'll take a look at that, depending upon if it's caused when you exercise or when the patient lays down, etc. So we'll take a look at the different types of pectoris angina, and then we'll talk about some different types of treatment for this. So a couple different types. Your stable or classic pectoris angina, this is what patients typically will experience. And let me make just a note. Female patients typically experience different signs and symptoms of a heart attack than a male does. So for homework, why don't you look that up and tell me what the differentiation between male and female heart attack signs and symptoms are? I don't know. Y'all tell me on Wednesday. Okay. We'll look at stable and then nocturnal, which is night, and then silent. So That's typically very bad, because what will happen is the patient will have no signs and symptoms, and all suddenly, bam, something has happened. Let's talk about treatment. For treatment, it's sort of reverse of what the signs and symptoms for pectoris angina is. We want to reduce the risk of death, obviously. We want to prevent a heart attack from happening. So patients will typically show signs of a heart attack a couple of weeks before the heart attack actually happens. We want to increase oxygen supply to the heart. We'll do all this through drugs. There's a couple other ways to do it, but again, drugs is the way we want to treat stuff, right? Throw drugs at problems. Reduce the pain and the anxiety associated with this. When the patient has chest pain, they're probably going to be have a little anxiety associated with that as well. So we want to reduce all of that. The patient can have something called a CABG. You may have heard of this before. And there's not a picture in your book of it. Did I put a picture of it? Yes. I have a picture of a CABG on the next page. Let me flip to it and I'll come back. So here's an example. So here is that obstruction. So all we did, there it is. So all we did is did a bypass. So this is your aorta, right? Which is going from your, which ventricle or atrium? The left ventricle to the rest of the body, right? So we have oxygenated blood here, right? So all we're doing here is we're bypassing that obstruction. So there's an example of a coronary artery bypass. So that's all that is. Did you get everything copied on this slide that you needed to? Okay. So I already talked about a bypass. So again, we're just bypassing that obstruction. Because before that obstruction, let me jump down and go back. I should have flipped my slides around just a smidgen. Oh, this isn't a good example. Okay. We did a stent, but for example, before the stent, let me draw a picture. Let's say right here, I'm just making this up, but we'll say this is where the obstruction was occurring. So what you would see is when the heart would beat, blood would flow, but blood would flow very gently down this area because it's obstructed here. So I don't know what area, but then all of this you would see very little of. This little tree branch. And this is an example of an angiogram. Now, angioplasty is and with stent is putting this in. So this is the stent. Yep. Okay, so when you do an angiogram, you would see this blockage, and you would see below that blockage, you would see very faintly when the heart contracts. It's really neat. I'll see if I can pull something up on break and show you. Okay, so here's the example of a balloon angioplasty. So again, we have the obstruction. We go into balloon, we push it to the sides, and then we go in with the stent, and then there we go. So the stent kind of holds it back. I believe they do it with metal or plastic composites. So again, there's the stent that's actually put inside. And now, as you can see, we have normal blood flow compared to the other arteries as well. Does it make sense? Everybody understand? Good? Mm-hmm. Y'all like, yes, I understand. Then when it comes quiz time, it's like, I don't remember. Okay, now let's talk about drugs. So we talked about the basic anatomy physiology. We talked about abnormal anatomy physiology. We talked about surgical procedures. We talked about the CABG. We talked about angioplasty. We talked about the angioplasty and stent, or the balloon angioplasty and stent. We also talked about angiogram. So we are very familiar with the surgical procedures. Now let's talk about the drugs that's associated with it. So some of the drugs used to treat is going to be nitrates. For example, nitroglycerin. There's different forms of nitroglycerin, and we'll take a look at those. Also, beta blockers. And last but not least, calcium channel blockers. And we'll break these down and look at these individually. Also, we'll take a look in Chapter 12 at beta blockers and calcium channel blockers to be being used to treat hypertension. Nitrates works well. And we'll take a look in just a moment. Vasodilator. Relieves the pectoris angina, comes in many different forms. It works well, works quickly. And it is a vasodilator. So nitroglycerin is a vasodilator. It dilates the blood vessels. Keep in mind that all we're doing is putting a Band-Aid on it. Okay? If you have an infection, you take antibiotic, you get better. The antibiotic will, depend upon what kind of antibiotic, it will kill the infection. If you have pectoris angina and we take nitroglycerin, all we're doing is putting a Band-Aid on it. Just a Band-Aid. It's not going to stop it. Well, it will stop the chest pain, but all we're doing is waiting for it to get worse or for us to have an angioplasty or a CABG or something. So we don't take nitroglycerin for 2 weeks and then we're better. And then we're all cured. Does that make sense? Okay, so it's just like putting a Band-Aid on it. So we're covering it up for now. It's a direct vasodilator. So. And we'll take a look at the different forms of nitroglycerin. But again, all it is a vasodilator. It's used to treat pectoris angina, and the sublingual route is the main way. We have sublingual spray, tablets, there's paste, patches, all kinds of things. Drips. So a couple different forms of nitroglycerin. As we mentioned, the tablets. Now there's sublingual tablets, but there's also tablets that you could take PO. There's tablets that you could take PO, which is sort of a preventative or a everyday type medication for nitroglycerin. And then we have the spray, where you spray it under the tongue. And we have the ointment, or sometimes referred to as paste, and then we have the patches. So nitroglycerin comes in many different ways. Also, there's a drip, an IV drip that you can do of nitroglycerin as well. Some adverse effects. There's a couple on here that are really important that I want to mention. And as I told you before, I'm only going to make you memorize the main side effects of certain drugs. Well, there's a couple here that's very important. Let me mention those. One is going to be this orthostatic hypotension. And think about it. If you think about it, it makes sense. Nitroglycerin is a vasodilator, right? So it's going to dilate the blood vessels. So by doing that, it's going to cause hypotension, right? Which is low blood pressure, right? Okay? Now, the next one is headache. That is a biggie. If you ever touch nitroglycerin, especially like the paste, then you will develop a headache. So you have to be very careful. And again, the reason that it's doing that is because it is a vasodilator. So it's dilating the blood vessels in your brain as well. Tachycardia. So the heart is trying to compensate for the low blood pressure. So the heart is beating faster to try to compensate for that. Because the heart says, ooh, the blood pressure is getting lower, I need to pump more. And then the other things on there are important, but those are the biggies associated with nitroglycerin. Okay? Everybody follow me so far? So if you have to put a couple down or you have to explain a couple, just remember what nitroglycerin is actually doing. It's a vasodilator. So think what happens when you dilate a blood vessel. Okay? Some drug interactions. A couple on here I want to mention. One, not just with Viagra, but also the Levitra would fall in this same category, because quick story about Viagra, I think I've told you before, when it was first in clinical trials, they were looking at Viagra to be used as a medication to treat hypertension because it is a vasodilator. But it had, one of the side effects, or more of a front effect, is that it also took care of impotence. So they changed it from being used for blood pressure to being used for impotence. So then they put it on the market, and then suddenly all these people were having MIs, and some people were dying. They're going, whoa, what happened here? And people were mixing it with their nitroglycerin. So nitroglycerin is a vasodilator, Viagra is a vasodilator. Okay, I'll move on. Now we're going to talk about beta blockers. There's two types of beta blockers. We'll talk about adrenergic beta blockers today. We'll talk about our beta 2 next week, or in chapter 12, whichever week that may be. So with our beta 1 is found in the cardiovascular system. Very good, very good. So the beta blockers will decrease the effects of the sympathetic nervous system. So look back on page 90. And take a look at your sympathetic versus your parasympathetic. Beta blockers are blocking that sympathetic nervous system, that fight response. They're blocking that. So by blocking the sympathetic nervous system, we have the decreased heart rate, decreased blood pressure, etc. Everybody with me? All right, moving on. By doing all that, the beta blockers used to treat, we'll get to that in a second. Beta blockers reduce the oxygen demand, so if it reduces the oxygen demand of the heart requires more oxygen, so therefore we're helping the heart out, right? Very good. You will see beta blockers, and we'll talk about beta blockers quite a bit next week as well when we get into beta blockers being used to treat hypertension. Also used to treat congestive heart failure, which is what we're doing here, because beta blockers causes the heart to need less oxygenated blood. So you'll see it used quite a bit with the pectoris angina and some adverse effects. Adverse effects of beta blockers. We'll talk about this week and again in chapter 12. Very important. Again, I only going to mention the important things. One, bronchial spasms. We typically will see this with our non-selective beta blockers because we have beta what receptors in the lungs? Beta 2 receptors in the lungs, right. The next one I want to mention is this hypoglycemia, because beta blockers can mask hypoglycemia. So what's the type of patient that would not be a good choice for beta blockers? Very good. Also one which is an odd one, but nevertheless it is one, and that's the last, depression. So put a patient on a beta blocker and they may give you a call and tell you that they are depressed. or they have become depressed. So that's something to monitor while the patient is taking the beta blocker. The bradycardia, that's just what, slow heart rate. So we would kind of expect that with the beta blocker because it blocks the sympathetic nervous system. And also the hypotension because that's kind of what we're inducing. And we'll talk more about the hypotension, the bradycardia next week or in chapter 12 when we talk about beta blockers being used to treat hypertension. So the biggie things that we've talked about with beta blockers today is the bronchial spasms. And we said because of beta-2 receptors are in the lungs. We talked about hypoglycemia because it can mask hypoglycemia, so we need to be careful if we give that to diabetic patients. And then I mentioned about depression. Contraindications, as I mentioned before, of the types of patients that you would not be a good choice to put the patient on, and I've already mentioned before. So diabetic patient, asthmatic patient, a heart block. So with a heart block, we're talking about like an AV block. Because the heart, the sympathetic, because the beta blockers block the sympathetic nervous system. So if the patient has an AV block, for example, we don't want to be blocking it more. And same thing with the bradycardia. So really should have those two switched. I'm not going to beat a dead horse. I've already talked about this. I'm going to move on. I don't know if you need to copy anything down or not, but I would say in case you do. But I've already mentioned this like 1,000 times, so I'm going to move on. Calcium channel blockers. I'm going to get a little ahead of myself. We'll talk about calcium channel blockers again in chapter 12 to you, and we'll give calcium channel blockers to treat hypertension. They're excellent drugs. Beta blockers are also used, and what we'll talk about today is used to treat angina and also certain arrhythmias. And next week we'll break calcium channel blockers into different categories as well. Today we'll kind of lump them together, then next week we'll break them up. I'm sorry? Yes. Okay, calcium channel blockers do exactly that. They block the reuptake of calcium. They are a direct vasodilator. They block the reuptake of the calcium into the cell. They are a direct vasodilator. Then when vasodilation occurs, you know what happens. Calcium channel blockers used to treat angina and uncontrollable nitrates. It can be used in combination with beta blockers. Also can be used to treat hypertension, which we'll talk about next week. But because calcium channel blockers are a direct vasodilator, we can use them to treat pectoris angina. MI, myocardial infarction. So another word for heart attack. And in medicine, or in cardiology specifically, there's a saying called time is muscle. Because the more time you wait, the more muscle dies. And once that tissue is dead, it is dead. You cannot bring it back. So that's why it's very important to treat it very aggressively. So MI is going to be this dead cardiac tissue. And as I pointed out before, what happens with the coronary artery, for example, you block that area, and then the area below that can potentially die because it's not getting that oxygenated blood like it's supposed to. So if it doesn't get oxygenated blood, we have this cell death occur if it's for a prolonged time. And then if enough of it dies, then we have a dead patient. There you go. This is also on page 175 in your book. So we see the injury, so we see all the injury around that area because that area is not getting oxygenated blood, right? So this area is potentially going to die if we don't treat this area aggressively and we don't treat it quickly. And not only that, this is a very important area, not that there's any part of the heart that's not important, because this is the left ventricle. So if we don't do something quickly and that tissue dies, that muscle dies, we're going to be in major problems. Goals. We want to relieve pain. We want to relieve the muscle or the tissue death, the neurosis. And what we can do is we can confirm this by an EKG and also by certain markers. So there are certain things that are released if an MI happens. One of those is troponin. So you may hear a patient being admitted for 23-hour observation, and they draw certain what they call cardiac levels on a patient. They're looking for certain markers which is indicative of a MI. So if the patient has certain markers, then they've had an MI. Pain relief, so give oxygen, give the nitroglycerin, which is a vasodilator, and give, they have morphine sulfate, so to give something for pain. And okay, so we'll pick up where we left off on Monday, talking about antithrombolytic medications. So these medications are going to be used to treat a patient who is having an MI. Medications here are different types of medications, which is going to be a blood thinner. So we're giving heparin, or might also give low molecular weight heparin, such as Lovenox, warfarin or Coumadin, aspirin. Aspirin, this is pretty much going to be a give-y. And antiplatelet medications as well. Now, I'm not going to go into too much detail about the electrical activity in the heart. I'll touch just a little bit on this because we're talking about medications to treat different arrhythmias. And some medications may affect the normal electrical activity in the heart. So we'll discuss that as well. We'll discuss that a little bit today, and we'll discuss that sort of periodically throughout the rest of your education career. Because certain medications will increase this QRS complex or affect this in different ways. We'll take a look at that in just a moment. Okay. You may want to make a note because we're going to talk about medications which are going to be affecting this. So if you're questioning, well, when does ventricular repolarization occur, you can refer back to this particular chart, etc. Okay, moving on. I don't expect you to memorize these. I'm just going to show you some of these, but I'm not going to throw these on the midterm or final and go, okay, patient is having this arrhythmia. What is it? This is just to show you. So I'm going to go through this relatively quickly, but this is just to show you some of the different types of arrhythmias. Then we'll talk about some of the drugs used to treat them. Notice the heart rate. So what's happening here is the heart's just going crazy. It's just firing, but it's not actually pumping like it's supposed to be. Now what happens during the pumping stage of the heart is the atrium, both atrium, right and left, will contract, and then the ventricles will contract. So the atriums and then the ventricles. Atriums and then the ventricles. And they do it together. Both atriums contract at the same time, and then both ventricles contract at the same time. Does that make sense? Okay. So it's not like the right side of the heart contracts and the left side of the heart contracts. It's actually toward the top and the bottom. The atriums contract, and then both ventricles will contract at the same time. I probably should put the normal one first, but I did not for whatever reason. But anyway, I'll change that in the future. I'll move this slide to the beginning, so you'll see what the normal looks like, then the abnormals. Anyway, you can look back at these at some references. Here's this bradycardia, which is what, slow heart rate? Okay. So the different types of arrhythmias, this is going to affect the heart's pumping cycle. So as I mentioned before, we have the atriums contract and then the ventricles contract. So if there's some electrical activity in the heart that is going bad, then the pumping action of the heart is going to be off. So what we can do is we can give certain medications to help, and those medications we'll get to in a moment. So can result from damage to the heart conductive system, so the electrical system of the heart. If there is any electrolyte imbalances or abnormalities, fever, hypoxia, stress, drug toxicity. And we'll spend some time on drug toxicity toward the end of this lecture. We have a study. I'm not sure. I could have told you the study before the study was conducted. But patients who have diagnosed for the first time atrial fibrillation have a greater chance of dying compared to those who do not have this condition. I could have told you that before the study happened. So if you have some form of arrhythmia, chances of you dying before a healthy person is much higher. That's basically what that's saying. So some factors associated with this, a faster heart rate, being thin, and a history of chronic kidney disease. So all these play a factor with atrial fibrillation. This is a biggie here. When we talk about these medications are not going to cure whatever is causing the arrhythmia. It is just going to be a Band-Aid. We're just sort of covering it up, but we're not curing it. Just a Band-Aid. Okay. I'll slow down a little bit now. So we're going to be looking at 4 different classes, and then there's some subclasses in here. I'll try to go easy on you on the subclasses. But the 4 big classes of antiarrhythmic medication. 1 is going to be sodium channel blockers. And then there's some subclasses. I'll try to go easy on you there. But the 4 classes. 1, sodium channel blockers. Let me to help this make sense, let me show you something, and then I'll come back to this slide. But let me explain to you what we're doing here. When I talk about the different types of channels, this is kind of what I'm talking about. I'll go over this in more detail in a moment. But we're blocking this channel. We're blocking the potassium, the sodium, the whatever. But this is what we're affecting. So when I talk about this is a calcium channel blocker or a sodium channel blocker, or potassium channel blocker, this is what I'm affecting. Okay? Now, let's go back to the other slide. I just wanted to show you what we're talking about. Okay, so first one is going to be our sodium channel blockers. Next, our class 2 is going to be our beta blockers, good old beta blockers. And then class 3, this is going to affect the potassium. Last but not least, 4 is going to be our calcium channel blockers. So again, these are the 4 groups or the 4 main classes of antiarrhythmic medications. Class 1 is sodium channel blockers. Class 2 is your good old beta blockers. Class 3 is going to be the medication that's going to affect the potassium outflow. So class 4 is going to be our calcium channel blockers. Easy enough, right? All right. Now let's discuss the classes. So I told you to try to go easy on you on the subclasses. So here we're talking about the subclasses with class 1. So class 1, we'll talk about the subclasses. We'll talk about the sodium channel blockers. And what we're doing with the class 1 sodium channel blockers is we're decreasing the influx of sodium. So by affecting that, we are increasing the recovery time or the repolarization. So if you glance back at the electrical activity of the heart, the QRS complex, etc., you can see. Then we have, and we're still talking about the class 1, but we're still talking about those subclasses. So A, we're slowing the conduction and prolonging that repolarization. B, we're slowing the conduction and we're just shortening that repolarization. And then we're still in class 1, but prolongs the conduction with little to no effect on repolarization. So those are the subclasses in class 1. And all of those affect sodium. Okay? Very important. So even though we talk about A, B, C, we're still talking about sodium. Now, let's talk about our class 2. Class 2 is going to be beta blockers. Think back about what the beta blockers are doing. Beta blockers are blocking the sympathetic nervous system, right? So we're inhibiting or blocking the stimulation of the heart and depresses the myocardial excitability and contractibility. So we're just sort of suppressing the heart, saying, calm down heart, it's okay. Just relax, everything's going to be okay. Sort of coaching the heart. Okay, then our class 3, we're affecting potassium. So during that repolarization phase, we're going to prolong that action potential. So by doing that, we do decrease the frequency of the heart rate. So we are decreasing the heart rate. And last but not least, calcium channel blockers, CCBs. They prolong the nodal conduction and effective refractory period. So remember that we have the SA node, the AV node. So what happened here is they're just prolonging that action potential. So just sort of slowing it down, sort of putting the brakes on it. Now we'll talk about some indications. So when would we use a class 1, 2, 3, 4? That's what we're talking about here. So our class 1A, and you'll notice that some of these may be overlapping, but supraventricular arrhythmias, ventricular arrhythmias. So we're looking at class 1A. Class 1B. So again, with chronic ventricular arrhythmias, ventricular tachyarrhythmias. And here's a big one too, this digitalis. The last few slides on this PowerPoint talk specifically about lanoxin and digitalis. And part of that, you'll see how it actually works, how lanoxin works, and you'll see why the potential for overdose is so high with lanoxin. The therapeutic range and toxic range are very close to each other, and you'll see why. It works well, but if you take too much, it could be bad. And again, we're still in the class 1C, just various types of arrhythmias. Okay, class 2, this is going to be our beta blockers. So remember what beta blockers are doing, block that sympathetic nervous system. So arrhythmias due to this increase in this sympathetic activity, because beta blockers block that. And digitalis toxicity as well. So patient has digitalis toxicity. There's a couple things we can do. We could give class 1B, or we could give class 2, which are the beta blockers, to treat digitalis toxicity. Class 3, this is going to be our potassium channel blockers. Bless you. So our class 3 potassium channel blockers, severe supraventricular tachycardia and ventricular tachycardia. And then, last but not least, class 4, we have calcium channel blockers, CCB. And we mentioned before for certain arrhythmias, we mentioned pectoris angina and hypertension before, but here we're actually looking at some of the arrhythmias that calcium channel blockers are used to treat. Supraventricular tachycardia. Okay, congestive heart failure is abbreviated as CHF. You may want to make note of that if you don't remember that from terminology. And you'll see that on some case studies in the future, hint, hint. So when you say CHF, we're talking about congestive heart failure. Also, you can abbreviate congestive heart failure CHF, but make sure you know what that stands for. One of the most common disorders or cardiovascular disorders, that's what you'll see a lot of patients with congestive heart failure. And this is just when the heart is not able to pump enough for the demand. So this can also lead to something called pulmonary edema and peripheral edema. Have you heard of this? Depending upon if you have right side or left sided heart failure, or you could have complete heart failure, which is the congestive heart failure. So patient is walking from their house to their mailbox, for example, and they become very, very tired, very lethargic, just doing short activities because their body is not able to get enough oxygenated blood. Treatment goal is to treat removing the underlying cause. So if, for example, they have pulmonary edema or peripheral edema, etc., you would try to relieve that. If there's some type of arrhythmia, whatever the case may be. Okay. Cardiac glycosides. Great drug. This is autonomic or digitalis that we were talking about. Oh, by the way, with congestive heart failure, basically we're just treating whatever happens. So if the patient is having edema, we treat that. One of the drugs that we can give for congestive heart failure is beta blockers, because the beta blockers help with the oxygen demand on the heart. So, cardiac glycosides. It's been around for a long time. And it comes from a plant, the foxglove plant. Okay, so what happens, and the reason that we have such a narrow therapeutic range, is my marker stolen. Okay. Okay. So before I explain this to you, let me give you an analogy. Let's say that you are watering your garden or flowers or something, and you're at the end of your water hose and you have a plant on the other side of a sidewalk, for example. What do? You put your thumb over the end and you increase the pressure, and the water squirts over there and waters the plant. You with me? Make sense? Everybody with me? Good? Okay. That's how Lanoxin works. Any questions? Okay. So what happens when we take Lanoxin? We have these channels. Okay? And when we take Lanoxin, we are blocking. So these channels moving back and forth like it's supposed to be. But with Lanoxin, it's going to help the heart contract stronger. So what we're going to do is if we block off, let's say, in my example, well, let's block off 2 of these channels. So we just have this one channel. So now, instead of multiple channels that we're having this exchange happen, we only have one channel that this is happening. So we're going to have a much higher concentration at that channel, right? Now, the reason that digitalis toxicity can occur is if we block too many channels. So this, for example, would be that. But let's not block this channel. Let's keep at least one open. There's more than one, but for my example up here, we just have one. So now, because we have this channel open, and we have closed some of the channels, we're going to have a higher concentration. So we're now putting our thumb, if you will, over the channel or over the water hose, so we're going to have a higher concentration. Make sense? So there you go. I was going to mention something else, but I forgot.
How do you know how many channels?
You don't. You don't want to do that. No. As long as you get the proper dose, you're fine. It's when patients take too much, or if the math was done wrong and too much was injected. But you also could draw levels too and see what the dig level is. Okay, so cardiac glycosides increase the speed of the myocardial contraction, and they make that a stronger contraction. Okay, I've already mentioned that. It increases the force of it. And it can also be used to treat certain arrhythmias. So atrial fibrillation, flutter, atrial tachycardia. And it's prescribed mostly orally. In the hospital, they can do injection as well, but you have to be careful because of that therapeutic range, that toxic range are very close to each other, so you have to monitor that. And as I mentioned before, they act by increasing that force of the contraction. So the heart's going to contract more efficiently, if you will. Indications for our cardiac glycosides are going to be used to treat heart failure and certain arrhythmias. So control the ventricular rate if there's atrial fibrillation or flutter, and to treat or prevent recurrent atrial tachycardia and pictorial angina. Adverse effects. So the potential for dysrhythmias, so if a block too much, particular patients with hypokalemia. So if the patient has low potassium, digoxin might not be such a good choice to put that patient on. So potassium is a biggie that you need to monitor here. Hint, hint. Okay. Okay, go ahead and take a look on page 176, table 11-3. So we're looking at the different arrhythmias and look at the beats per minute. So for example, bradycardia, which is low heart rate, we have less than 60. And then with tachycardia, you have between 150, 250. Atrial flutter, between 200 and 350. Atrial fibrillation, more than 350. And then the other ones are variable. Now, we talked about, on page 177, we talked about the different classes of drugs. We talked about the sodium channel blockers, the beta blockers. We talked about the potassium channel blockers, and we talked about the calcium channel blockers. Now, let's take a look at what some of these drugs are are in these classes. So if we look at class 1A and our class 1, which is going to be A, B, C, all these fall into sodium channel blockers. Lidocaine, for example, is a class 1B. So, oh, I forgot to show you something. I'll show you that in a minute. I would learn your favorite drug in each of these classes. So that's what, 1, 2, 3, 4, 5. That's 6 drugs. So I've got faith that you can memorize 6 drugs. So whatever your favorite drug is on class 1A. Now on 1A, know that 1A, or know that your ones, your class 1s are all going to be sodium channel blockers. Does that make sense? But know your favorite sodium channel blocker in class 1A, 1B, 1C. Whatever your favorite one is. Class 2, know that that is a beta blocker, and go ahead and pick your favorite out. Class 3, know that is a potassium channel blocker, pick your favorite. Class 4, calcium channel blocker, pick your favorite. You got 2 choices. Does everybody understand? Okay, so those are your, so I can ask you all kinds of questions on that. Obviously, I'll ask you to give me an example of that, and then you know the sodium, the beta, potassium, and calcium channel blockers, and able to give me an example of those. And then on your class 1A, know your 1A, 1B, 1C, a drug within those. But all of your class 1s with sodium channel blockers are just class A, B, and C. I've got I got a few more minutes. Let me show you something else. I will be passing this out next class period, but I'll go ahead and show it to you now. But again, I'll pass this out and I'll put this up on Moodle. Some drugs are associated with QT prolongation. So certain drugs will cause, or a potential of causing the QT interval to be extended, which could allow for an arrhythmia to happen. So if a patient has a history of arrhythmias, for example, certain medications might not be a good choice to put the patient on.
It's in our pharmacology too.
Oh, okay, that's good. So I've got a little 3-page paper here that I meant to make copies of today, and I did not. So I'll make a copy of this and briefly talk about it on next Wednesday. Okay.